I'm an associate clinical professor here at UCLA in the sarcoma program. And the reason I was given, but immunotherapy is a very close subject, close to my heart, a subject. I've been dealing with immunology and immunotherapy for probably right now more than 20 years. When I was, how many years ago? It was 17 years ago when I was writing my PhD thesis in immunology on T-cell specificities and development of T-cells and the use in different therapies. People were laughing at me. I said, you know, why would you, I mean, it's interesting to study biology, it's interesting to study immune system, but who needs it? Who needs it? We know that it works well to fight infections, but can it be used for something else? So we had, at that time, of course, multiple people already knew that maybe we can use immunotherapy to treat cancer. And the first signals were actually in melanoma, and kind of half of my practice is melanoma, half of my practice is sarcoma. So this was one of the reasons I came here to UCLA and joined melanoma program, because there was so much progress in immunotherapy in melanoma. But these days we know it's not only melanoma, but it is also applicable to other cancers. Okay, so let's start. So generally, since I'm going to talk about immunotherapy, what's the difference between immunotherapy and other types of therapies? So when we generally think about, and I try to make it in a very simplistic way, when we think about therapies, systemic therapies for a patient with cancer, we could imagine when we could target the tumor. The sarcoma started, let's say, in the arm and traveled to other places, maybe the liver, maybe the lung, maybe the bones. And our traditional chemotherapy, so all the agents, doxorubicin, ifosfamide, gemcitabine, docetaxel, and so on, or even the newer targeted therapies like pazopanib, they target directly the cancer cells. So they have to get where the cancer cell is, interfere with the mechanism of the growth of this cancer cell, and stop it and kill it. But we can imagine immunotherapy works in a very different level. Immunotherapy drugs, majority of them that are currently available or in studying, have actually no direct effect on cancer cells. They do not, most of them do not bind to cancer cells. It's not completely true, but do not bind to cancer cells, do not interfere with the machinery of the growth of the cancer cell. What they do, they alter or change the immune system, so the natural system that we use to fight infections, and this will allow the immune system to recognize cancer, something should not be there, and possibly eliminate it. And some of you are my patients, so probably we had the similar discussions before, but it is one of the most common questions if a patient is diagnosed with cancer or metastatic cancer, to say, what can I do to boost my immune system? This is one of the, and I usually disappoint my patients because I tell them, you actually cannot do much to boost your immune system. I mean, yes, there are diets and supplements, but the fact that because there's an implication with it, when the immune system is not working well, and that's why I have cancer. But 99% of patients have normally working immune system. Yes, there are occasional cancers that happen in patients who have impaired immune system, but this is actually an extreme minority of patients. Because these patients who develop Leiomyosarcoma, these are not the patients who have infections. You are protected, we are protected from bacteria and viruses like people without cancer are. So your immune system is working very, very well. What happened is the cancer found the way to outsmart this perfectly working immune system. So they must have found the molecules, the pathways, and so on, when even if the immune system is working very well, they can escape the surveillance done by the immune system. So what is the immunotherapy? I already kind of told you when we are trying to harness the power of the immune system and use it to detect and destroy the cancer. Why is it so? Why can it be so effective? Sometimes it is effective, but because the immune system is extremely specific. That's why you get your MMR shot as a child, and you don't develop measles or mumps later on, because the immune system it's not that the virus is not around us; it's somewhere there. But if we are exposed to this, the immune system is able to detect it, eliminate it. Also, the immune system can adapt to the changes. So if the virus changes a little bit or bacteria changes, your immune system can adapt to these changes and try to still eliminate the infection. And the immune system has memory. This is how the vaccine works. Or the fact that you might have had a chicken pox before times of vaccination, and you will not have chicken pox later on because your immune system will remember for the rest of your life that you had chicken pox. So this could be used, this one. So kind of, this is similar information as the previous slides. Immune system is extremely diverse. The cells that fight cancer are T cells. It's a subgroup of immune cells, and the number of T cells in our body is 10 to 18. Antibodies help with fighting of cancer. They are right now parts of the therapy, but a direct destruction of tumor cells is caused by T cells. And we talked already about specificity and memory. So the next question is, what would be the mechanism of immune responses against cancer? This becomes a little bit more complicated when I'm showing you this slide. But the main reason, and we are not going to go through this slide so much in detail because it would be too much of immunobiology, which is very interesting. But what I wanted to show you, the whole process, this is a whole process which has multiple steps. And it must be an antigen coming from the tumor, then is presented by specific cells. The cells go to the lymph node, to the areas where the T cells sit. They present to the T cells. The T cells must be activated, get out of the lymph node, go to the circulation, and find the tumor and possibly destroy. So there are several steps, and on each of the steps, cancer can interfere and break one of these, maybe block the molecule, maybe secrete the substances that do not allow the cells to differentiate. Maybe the T cells they do get activated but cannot penetrate through the tumor and do their job. So on every single level, there might be abnormality. And you can reject cancer, get rid of cancer, only if all the steps occur in sequence and without any problems. That's why the immune system, the cancer, when it's generated randomly, can use some of this mechanism. And we are trying to understand it and try to interfere and restore this mechanism so the immune responses can occur against cancer. This is an example of T cell sitting in a lymph node, and it's being activated by the dendritic cell. And one of the molecules, which is a natural breaker on our immune system, is called CTLA-4. This is a natural break. I always give the same example to patients. You say, we use the example of a car. Yes, if the infection gets to your body, the immune system has to accelerate. So you have your accelerator, you push on a gas pedal, and the immune system starts fighting the infection. You might be having muscle aches and chills and fever because the cytokines are secreted, there's a response. But it's not enough to take the foot away from your accelerator to stop your car. You need a break. You need a break, and otherwise you would have fevers and chills and muscle aches for the rest of your life. So immune system develop natural breaks. Then if we do not need the response anymore, then we put the foot on the brake and we stop the car. And one of these natural brakes is CTLA-4. But what's happening right now, we understand the cancer may use this molecule to escape, to block the responses against the immune system. So and this is something what's called a natural checkpoint. That's why we are developing the drugs that are checkpoint inhibitors. So if we can, there is an antibody right now called Ipilimumab that can block this molecule, and this drug is approved for patients with melanoma, and the T cells can get activated, leave the lymph node, and go to the tumor cell. But in the right now, in the tumor environment, we see that there are other molecules, such as PD-1, which is another natural brake on the immune system on T cells. And the cancer may have a matching ligand for this molecule. And as the T cell arrive to the cancer environment, cannot do the job because cancer is using the natural inhibitory mechanism, what we use to control our immune responses, to escape the response against cancer. Okay, so, of course, what's happening, what's exciting right now about immunotherapy is the development of the blockers of this interaction. So we are talking right now about leiomyosarcoma today, but I can tell you that, as I told you already, Ipilimumab antibody blocking CTLA-4 is approved for patients with melanoma. Antibodies blocking the PD-1, PD-L1 interaction, there are 3 drugs currently approved. One is called pembrolizumab, nivolumab, and the third one, atezolizumab. Pembrolizumab is approved for head and neck cancer, melanoma, and lung cancer. Nivolumab is approved for melanoma, lung cancer, Hodgkin's disease, and bladder cancer, and kidney cancer. Atezolizumab is approved for lung cancer and bladder cancer. So we know that this is not anymore, as I told you when I started studying immunology, we were saying, okay, it's going to be only melanoma, maybe kidney cancer. We know that it's happening in other cancers too. So it's natural when we should try these therapies in patients with sarcoma. So I'm giving you the data which were presented about 7 months ago during our annual conference. And we did run the trial of pembrolizumab in patients with soft tissue sarcoma, in patients with bone sarcoma. It was a smaller study. In soft tissue sarcoma, there were 40 patients, and 10 of these patients had leiomyosarcoma. Unfortunately, when we look at the results, not a single patient with leiomyosarcoma responded to this therapy. About 6 out of 10 had stable disease for about 12 weeks, but we don't know. It might have been the benefit from therapy, or it is that when the cancer grew more slowly. So the results of the study were somewhat disappointing. At the same time, another trial, so I told you when one drug is pembrolizumab, the other one is called Nivolumab. At the same time, the results of another Nivolumab trial were presented in patients with metastatic leiomyosarcoma right now of the uterus. And again, here the initial group was 12 patients that received Nivolumab, and unfortunately not a single patient responded in this group. So we have 2 very small trials, 10 patients with pembrolizumab, 12 patients with nivolumab, and not a single patient responded. Does it mean that this drug do not work? No, it is not true. They do work, but does it what it may give? It gives us a message that probably leiomyosarcoma must be using a different mechanism to escape the immune system rather than PD-1. And so that's why I started with this whole cycle, when there are multiple steps in immune responses, and this might not be the one that cancer is using to escape the immune surveillance. Or there might be more than one. Maybe it is using PD-1, but it's using something else, and that's why this is not sufficient. Having said that, of course, everybody, and when on leiomyosarcoma groups, I think there are cases right now of 2 patients, and everybody, this is in one example of a patient who was not included in the clinical trial, but she had a leiomyosarcoma and received nivolumab, and you see a large tumor here, and then a large tumor here, and after the therapy of nivolumab, these tumors shrank. So we know that there will be occasional patients. Unfortunately, with current knowledge, we still don't know how to find these patients. And with the number of patients we have, we know it's not going to be majority of patients. So in melanoma, when we use pembrolizumab, at least 70% of patients have some shrinkage of the tumor. Not everybody eliminates tumor, but have some shrinkage. This will not be 70% for patients with leiomyosarcoma. So we are talking that we are blocking this PD-1, PD-L1 interaction. Is it possible that actually leiomyosarcomas do not express PD-L1, and this is the reason this interaction, the drug cannot work at the site of the tumor? And yes, this is again the study presented during our ASCO, showing that only 1 or 2% of sarcoma patients, had an expression of PDL, actually 3% exactly, more than 10% on 10% of cells, and 11% of cancer had an expression of PDL1 on more than 5% of cells. But the next slide, I'm going to show you another slide showing that our research on expression is not very good either, because other groups previously showed that, for example, this group in leiomyosarcoma had 4 patients with leiomyosarcoma and no one had expression of PD-L1 on the tumor cells. But this group, if you can see, had leiomyosarcoma had 20 patients, and they say that 70% of patients had expression of leiomyosarcoma, which tells us that even our detection methods are not really very well established. We are getting there. There are tests commercially right now available that are useful for patients with lung cancer but can be applied to other cancers. But it tells us that there is a discrepancy or even between labs, what we see, how reliable is the result. And we cannot say if actually this expression will predict for response in sarcoma at all. But this will be the first step. So people are saying, okay, we are somewhat disappointed. We know that these are breakthrough drugs. Everybody's excited. We know that the immune system can do magic. So can we do something else? So yes, there are other attempts. The clinical trial of a PD-L1 inhibitor. In this case, they use, I think, atezolizumab plus a vaccine. There are other vaccine trials in combination with chemotherapy or vaccines generated for tumor cells, completely different approach. In the checkpoint inhibitor combinations, we have alliances running ipilimumab and nivolumab combination. So let's block in 2 places. I told you ipilimumab, CTLA-4, nivolumab, PD-1. What if we use them together? There were already early results of a combination of a therapy of pembrolizumab, so PD-1 blocking antibody with axitinib, and axitinib is another drug which is somewhat similar to pazopanib, which is a sarcoma-approved drug. It works through the probably blockade of the formation of new blood vessels. And these results was in a small group of patients, some promising. What if we Dr. Kalbasi was talking about combination of radiation therapies as an initiating factor to initiate the immune responses and then use PD-1. So there are trials like that. Here is what's happening to my mouse? Okay, the last trial is combination of chemotherapy. Then there is a combination of pembrolizumab with gemcitabine docetaxel. Recently was announced that there will be a trial of a new drug, of course, in sarcoma, which is olaratumab, and there will be a combination of olaratumab pembrolizumab trial ongoing. So this will be another approach. But it's not only that. We can create T cells that are specific for sarcomas. This is used mainly in liposarcomas, but does not have to be, which is something what we call adoptive T cell therapy. So there is, as you see, I'm showing you a few. It's not all of these trials are just for leiomyosarcoma, but the patients with leiomyosarcoma can be included. Many of the trials are smaller, or they have a lot of restrictions, so not everybody can go on the trial, but there are new approaches trying, so we are not giving up on using the immune system to fight leiomyosarcoma, although our initial results were somewhat disappointing. So I promise I'm not going to talk too long. There are other clinical trials that are currently ongoing and interesting, and they are not necessarily related to the immunotherapy. The one which is, as you saw, we actively participated in the trial that led to the approval of olaratumab in patients with soft tissue sarcoma. We're trying to go further. We finished accrual. Dr. Singh was the principal investigator on on the phase 3 trial of doxorubicin olaratumab. These patients are right now in follow-up. So we're trying to see, can this drug be used with other forms of chemotherapy? We know that olaratumab by itself has limited activity against cancer. It has to be combined with chemotherapy. But is it specific only for doxorubicin, or can it be combined with other forms of chemotherapy? And the commonly used chemotherapy in leiomyosarcoma is gemcitabine docetaxel. So we are running the trial. It was with all the trials we enroll some patients, we follow them, we hold enrollment to see if there's no toxicity, because we don't know olaratumab can make this chemotherapy very toxic. We were about to reopen for a few patients again, and we'll follow them for about 2 months. And if there's no increased toxicity, then it goes, unfortunately, to randomized trial. So half of the patients will get 3 drugs, and half of the patients will get gemcitabine docetaxel alone. Other trials which are interesting in France, it's ongoing in France, is combination of pazopanib with gemcitabine. Then trabectedin, a new chemotherapy drug approved for patients with leiomyosarcoma and liposarcoma, is being combined with doxorubicin. This is an extremely important trial, especially for patients with uterine leiomyosarcoma. We still don't know if actually giving chemotherapy immediately after surgery, after removal of leiomyosarcoma from the uterus, and with a successful surgery. So I'm not talking that something is obviously left behind, but we think that the surgeon thinks that they removed everything. We do the scan, we see nothing on the scan, but we know from the features of cancer that the patients may have they do have a high risk of recurrence. So with many patients, I have a long discussion saying, if we want to do everything possible, then we offer chemotherapy in this setting. But if you tell me if I have a proof that this chemotherapy prolongs life in this setting, no, I do not. So gemcitabine docetaxel probably does not prolong life by itself, but may delay recurrence. Doxorubicin not. So we're trying, okay, let's do all together. And after gemcitabine docetaxel, if we give it, then the patients will receive on top of it doxorubicin. Having said that, very important misinterpretation of trials in what we call adjuvant setting. The trials in the adjuvant setting are to achieve success. The chemotherapy has to be given in full doses and on schedule. So if the patient develops significant side effects because of this therapy, and you have to reduce doses, it's unlikely that they are going to benefit from this therapy in the adjuvant setting. It's not impossible, but it's unlikely. So if the treatment is so toxic for them, it's better to stop this treatment rather than expose yourself to probably unnecessary toxicity and hope the best when the cancer will not come back. And use this treatment again should the cancer come back. Then other trials is doxorubicin nilotinib. I would say this, for me, is less exciting. We will be opening the trial of a new small molecule called unlotinib. Hopefully, the early data actually on Chinese population were presented, and there was a promise in some subtypes of sarcoma. And there is a new drug, ribociclib. It will be approved very soon for patients with breast cancer. It's similar to the drug which is already approved, is palbociclib we use for some types of sarcoma. We'll be combining it with doxorubicin. So there is ongoing research. In this short presentation, I wanted to give you an update what we currently know about use of immunotherapy in leiomyosarcoma. Unfortunately, I don't think I delivered great news, But what is good news is when we are not giving up, trying to develop new combinations and try to understand why leiomyosarcoma or other sarcomas are actually different from melanoma and maybe from lung cancer or other cancers. Okay, that's all. Any questions? Yes, please.
This is sort of, I took my wife to MD Anderson at one point in the 90s.
Mm-hmm.
And the doctors there at the Sarcoma Center also treated melanoma patients.
Mm-hmm.
And I've seen that in other institutions, that a sarcoma doctor is also part of the melanoma program. I'm curious as to why. Are there...
Yeah, so this is this is a dying breed of doctors, you know. There is no particular reason to combine this. You know, there's no particular reason actually to combine. In the past, we thought, but this in the past, like 20 years ago, we thought when these tumors are somewhat related, when in the development. They are similar, but actually we know that they are not. They are very different. They are very different tumors. What's similar about them? They are not carcinomas, either of them. So they are not. So they don't start from lining of different ducts. You know, it's not. It has nothing to. Not similar to breast cancer. Not similar to colon cancer and all of this. And what's also was similar at this point, they are somewhat rare. Both of them, you know, about 10,000 patients die of sarcoma every year. About 10,000 patients die of melanoma. Melanoma by itself is more frequent than sarcoma. And at that time, when the programs were combined, there were no good therapies for either. So these were hopeless doctors who didn't know what, says, my God, I will be the one who will be delivering bad news in kind of combined. But as the knowledge grows and the treatments grow, in most of the places it separates. It just happened in me when I did so much research in melanoma, and the sarcoma program was growing, so I said, okay, let's do both, and I continue doing both. But it's a rare type of. I'm a rare type of doctor. Mm-hmm. Yes, please.
When you say full doses and full regimen, what are we talking about cycle-wise?
So what I'm saying, what I'm trying, and this is a very important message, which I don't know how important it is for patients, but it is important definitely for physicians in training. There are two different goals if you give chemotherapy. We always hope for cure, but if a patient has disease that spread to other places, then we know that the chances for complete cure is much lower, if not nearly zero. So we want the patient to live with the disease, and that the disease doesn't cause symptoms. So in such a setting is, if we give chemotherapy and makes the patient feel terrible, or we give any medication make them terrible, then this is a reason when we should reduce the doses. They're still active against cancer, but don't try to tell the patient, toughen it up, make your life miserable, I know that you cannot enjoy what you are doing, but we are giving you the drug, continue. So this is not the goal. But if the patient underwent surgery and we see nothing on the scan, and we hope then we can improve cure rate, then this is the reason try to say, okay, we'll give you 4 cycles of therapy. It will be harsh, but let's try to toughen up and keep the doses. On the other hand, I'm saying, if you cannot do it because you end up in the hospital and you spend more time in the hospital and your recovery from the hospital is a month or 2 because of the side effects of chemotherapy, then it's probably better to stop this chemotherapy, not to give you more, than rather to try to reduce significantly doses, give you chemotherapy here and there. But traditional for uterine leiomyosarcoma, we do 4 cycles of gemcitabine docetaxel, and if we on this trial will be 4 cycles of gemcitabine docetaxel followed by 4 cycles of doxorubicin. If this is a question, but yes.
What are the typical side effects of
Okay, I didn't talk about it very much because so the side effects, depending on the type of therapy, but the drugs which are of course approved right now, ipilimumab, pembrolizumab, nivolumab, and atezolizumab, we are unleashing the immune responses, but we are unleashing them in a non-specific way. Nothing is really showing this PD-1 and CTLA-4 are not part necessarily of something that's specific for cancer. So we are unleashing this immune system and we hope go where the cancer is then destroyed, but it may happen when actually this says when our body is using the same molecules to protect ourselves from the immune system. So it may that the immune system will go to the bowel and cause inflammation of the bowel, and which will present with severe diarrhea. It may go and cause inflammation of the liver. It may go and cause inflammation of the lungs, inflammation of the kidneys. Some of the side effects, so luckily it does not happen in everybody. If you use this single agent immunotherapy, the significant side effects happen probably in fewer than 15% of patients. Having said that, there were patients who died because of the side effects. The immunotherapy led to such a significant inflammation of the bowel that it led to perforation of the bowel, and they died because of a bowel perforation. We had patients who developed kidney failure because the immune system went against their kidney and they required dialysis. We had patients who developed brain inflammation and required admission to the hospital. They recovered completely, but they were in the hospital for 6 weeks on high-dose prednisone to reverse this activity of the immune system. So the side effects can be significant, and occasionally, right now we have new reports when immune system, with the use of these drugs, immune system can turn against your heart and cause inflammation of the heart with development of congestive heart failure. It happens in 1 per 500 patients with the heart problems, but it can happen. So we are unleashing it, and we hope it goes where the cancer is, but it can go against other places. On the other hand, I think it's one of the safest therapies. What's the difference between, if you get chemotherapy, everybody gets side effects. Not everybody has to have terrible side effects. With immunotherapy, probably at least 50% of patients will have completely no side effects. The rest will have some, manageable, and the small percentage on a single agent, like 15, a small percentage, 15. So I'm not trying to underestimate. I told you there's horror scenarios. Yes, it can happen, but on the other hand, it is a safe therapy. Yes, please.
Any statistics on the rate of reoccurrence of melanomas? Does it depend on where it is?
So yes, it depends on where it is, and as I said, use your circulator on your phones, your app. So it largely depends the rate, the grade, the size, the location, and all of this. We think that generally speaking, about 40% of patients survive 5 years. But there are, for example, cutaneous leiomyosarcomas. These are quite a benign disease, especially if it's of a smaller size. If it's subcutaneous, so might be the same size, but it makes it already more aggressive disease. So it's difficult to put them together. Yeah.
Is there potential for many of these immunotherapies or anything that could lead to a vaccine to prevent the reoccurrence?
We've tried. We had a sarcoma trial with one of the, yes. So the answer is yes, but we've tried. We had a larger trial with patients, higher risk patients, so underwent surgery and for metastatic disease. So we already know that the disease spread, but we do the scan and there's nothing over there. And half of the patients got placebo, half of the patients got vaccine, and there was no difference in between vaccine and placebo. So yeah, we finished this trial maybe 2 or 3 years ago. So yes, there are attempts, but unless we see activity in the patients who have measurable disease, it's unlikely then we will take it to the patients who had surgically removed disease and at risk for recurrence.